Okay, thank you.
Alright. Well, thanks for having me out. My name's Danielle. I'm a nurse from the Burn Center. How many of you guys have had one of our lectures in the past?
It's been a long time.
Okay, cool. So I've worked up there for about almost 23 years now, and love it, obviously. Otherwise, I'd just be crazy to be there that long. I've been coming out and teaching in the community the last 8 years or so. But my first time coming out here to Syracuse. But I'm from the north. I grew up in South Weaver, so this is kind of my neck of the woods. I have family right down the street, so happy to come out and teach our community too. So you guys feel a little more comfortable if you ever come out across, burn patients. By show of hands, how many of you have had that experience in your line of work?
A burn patient?
Uh-huh.
I was a burn patient.
You were?
I didn't go anywhere. He burned his
What?
mustache.
He burned his mustache off.
No,
It was very traumatic.
I was on a wildfire in a rural area, and I had like partial thickness burns on my elbows. There was really nothing. I wanted to keep working, so. But that was it.
Should've
There
flew
wasn't
out.
like anything big, but.
I went and taught an EMS class a couple months ago, and one of the kids was at fire training school. I guess I don't know what this is, but he had a fire extinguisher that they had just filled with air instead of whatever they're supposed to put in there. So when he shot the fire, it just got burned that way. But yeah, so fire training school. All right, so we're just gonna go over these are our objectives. We're gonna kind of talk about your initial evaluation, your primary and secondary survey of the burn patient, and then our three major things that we're wanting to watch on them: airway, fluid, and temperature are kind of our three big things. And then we'll talk a bit about trauma in relation to burn and not overlooking that. And then transport decisions, as well as we'll have a few case studies, so with some triaging, and we'll go through with some patient specifics. So disclosures, I have no financial disclosures. However, I'm not a first responder. I have to put that out up front because you guys are, and we get questions that I'm like, I know burns, but I don't know your world. So I might throw some of those questions back to the group if any of them come up. One other thing that's important to disclose up front is just the nature of our world today and the heightened risk that we're at. So we already know we live in an earthquake zone, right? So the question's not if, but when that happens. The university hospital, as well as primary children's, are kind of seated right on that fault line, and projections are that when it occurs, our facilities will be incapacitated. So given that, this community education is super important, because in our disaster planning with our disaster consortiums, it's anticipated that you guys may be holding on to patients in the community for up to 72 hours before we can get people triaged appropriately. So thank you a lot for having me out here today and preparing for that hopeful never but likely scenario. Mass gatherings, the civil unrest going on today. I mean, there's just every day more scary stuff coming up and potential for mass casualty events. In light of that, as far as burn beds across our nation go, there are less than 1,900 burn beds. One historical statistic that kind of puts that into significance is they said if one of the World Trade Towers on 9/11 had not fallen, there would have been over 2,000 burn patients in that building. So can rapidly exhaust the specialized burn beds. And again, another need for this community involvement and collaboration to prepare for that. Our center at the university has 15 beds. We do often surpass that. We'll send patients off to other units. They still come back down every day for their therapy, their wound care, their surgeries. think kind of at the busier months of the summer, which tends to be our busiest time. The most I've seen recently, a couple weeks ago, we had like 33 patients on. So it's kind of where we top out at. I think if we had any more than that, we might have to.
Was that during the 4th of July?
Yeah, so
Week?
yeah, usually July, end of June into July, people start camping, falling in their campfires, barbecues, trailers, all that fun. Fireworks season for our outpatient clinic is really busy. We also saw a lot of fireworks end up inpatient this year as well. The projectile ones tipping over and shooting into people's clothes and catching them on fire, things like that. So I don't love those fireworks being legal. Like, ugh. I also like just a weird burn nurse. Don't let my kids even play with sparklers, which they're like, why can't we have a sparkler? I'm like, no. But anyway, so yeah, fireworks, all the fun summer stuff just puts us at increased risk. So this is kind of our burn world, right? These are our regions, disaster regions. The blue being the western region, and then all those little dots are where the various certified burn centers are. Our particular region that we cover is 5 states. We cover Montana, Idaho, Wyoming, and then most of Nevada. So our patients come from like a vast geographic area of, we call it Mon Canada, the people way up there on the border. Their families are displaced from home for weeks to months on end. So we get really good at making the whole family comfortable there and have donations from the community for our family kitchen. They have a laundry facility, everything they need to kind of settle in for the long haul if they have a family member in our unit.
What's the justification of like opening another burn center in a state?
Oh, so it's kind of population based. I forgot I have swag. You've been very interactive. It gets better too, but you get a pen at first. It's population based, right? So that's why our region is so big, because we're not as populated. If you see in California, they have a lot more than we do.
Yeah.
There is a burn center in, I can't remember if it's Idaho Falls or Twin Falls, one of those falls towns in Idaho. They are not verified, so they have a surgeon who will do burn surgeries, and they have been taking some patients from like Yellowstone, the hot pots, things like that. But you have to do a lot of things to be verified, and you have to get re-verified. It's kind of expensive for the hospital to do that. So they haven't gone through that process yet. But that's kind of what it's based off of, is just need based off population. I have heard rumors that IHC might open one in Montana as well sometime in the future. So I can retire in Montana maybe one day, I don't know. That would
You'd
be
go
nice.
work for them?
If I could live in Montana, maybe. I don't know, it's a stretch. Anyhow, on our unit, we also see some other types of patients. We do frostbite, and then some other like large wounds like TEN or SJS, and necrotizing fasciitis. So wounds that need really good wound care, because burn nurses are really good at doing wound care and managing pain and anxiety during that. They also need our surgical services from our attendings for debridements and cleanups and potentially skin grafts too. So let's go ahead and talk about the kind of burns that you're likely to see. So this is just a few graphs with some data. This one here, you could see in pediatric patients, the primary mechanism is going to be scald. Little kids are at high risk for that, so plug to go home and check your water heater if you haven't. Most people's water heaters are gonna be around 150 degrees. If they haven't intentionally turned it down, we recommend turning it down to 120. Basically at 150, 160 degrees, especially kids or older people, because they're thin and their skin is thinner, they could get a very deep burn almost instantly from waters at that temperature. So we see a lot of kids in bathtubs, older siblings trying to help, or somebody turns on the hot water and they can't get out fast enough or turn it off. We also see people with seizure disorders get in trouble in this area as well, having seizures in the shower, or elderly people who just can't get out fast enough. And then as we get older, kind of turns and flame becomes the more common mechanism. So again, these July types of injuries that we were talking about before, as well as workplace injuries. So a lot of occupational risk for some people. This is the least surprising graph that I'm gonna show you today. It takes a minute for some people to figure it out. The light blue are the female numbers and the dark blue are the male. So if you are on my unit, you are most likely to be a middle-aged male. There's something on the Y chromosome. I don't think the geneticists have found it quite yet. I think they're gonna call it the dude hold my beer gene. I don't know. But I like to give you guys a hard time, but really a lot of that is occupational too, right? You guys are at increased risk with your occupation, as well as our electrical workers, linemen, people like that. So there's a risk there. This is a reassuring graph for me. This is basically our admissions based on body surface area. So when we plan and prepare and we educate, we're always picturing this big burn patient, but it's kind of reassuring to see here that actually those are pretty small numbers, kind of the dark blue and red, total number of patients we see with that large of injury. Most of the patients we see are gonna be more in that 11 to 30% range, which is a much more survivable injury than the other two. I think I was gonna ask there, it was a couple of years ago, or maybe only a year ago, we did get a patient from this neck of the woods. I wonder
Was
if
it
you,
in Layton for an explosion?
no, it was
It was,
a
North
young
Davis.
boy, like
North-
burning
North
something in the
Davis,
backyard.
North-
fire.
It was, yes, the department north of us.
Oh, okay, yep. That was one of these 99 percenters, miracle that he made it to us, and kudos to that crew out there who were able to get access and an airway on him. Really, really commendable. But yeah, those injuries are, not surviving most of the time. If you're above that 90%, it's usually kind of comfort care and religious services and allow the family to say their goodbyes and things. So, any questions so far? We could dig into our initial assessment. All right. So, the first thing that you all should be aware of and prepared for is the visual factor related to burn injury. So, it will distract you. It's highly distracting. First responders, you see the burn, and all you see is the burn. We just like to remind everyone to say, okay, I remember them telling me that this was gonna distract me and throw me off my game. Ignore the burn for a minute and stick to your ABCs. The burn is not going to kill your patient right away, but if you miss another trauma that may be going on, or carbon monoxide poisoning or something, or serious airway problem, and by being distracted by that visual factor of the burn, then your patient might die. But immediately, right up front, burn patients have this huge adrenaline response, right? They should be GCS 15 and whoa, totally fine talking. But if they're not, you should be looking for other things. If they're hypotensive initially, you should be treating that with your trauma protocols, not getting hung up on burn fluid resuscitation. But be prepared for the visual factor and how that will kind of throw you off your game. In our primary survey, so just like with the stuff you already know, it'll go A, B, C, D, E. Airway, C-spine precaution is an important one to remember in electrical injuries. So even if they didn't have a fall associated with their electrical injury, the high voltage current can sometimes cause fractures, cervical fractures as well. So all high voltage electric should get a C collar. And then just checking for patent airway. Breathing, you're gonna be looking for any signs of respiratory distress, stridor, work of breathing. Do they have soot in their mouth or nose? Do they have pre-existing medical conditions that might exacerbate what they have going on with their burn? Additional considerations for early intubation. So if it's a large burn injury and if you're burned less than 20% of your body, you're going to swell where you're burned. If you're burned greater than 20% of your body, as we start that fluid resuscitation, you're gonna swell globally. So if you're looking at someone who has a big burn and considering transport times and things, it might be a good idea to protect their airway if you're expecting that they're gonna have a lot of swelling. Burns to head and face, deep burns to head and face are also things that you wanna be assessing for in considering that early intubation. We'll go more into detail in airway in a few slides here. Cardiac, so they should be tachycardic, mildly tachycardic. If they're over 120, something else is going on, so you'll want to evaluate that. And also people on beta blockers, they might not be able to mount that response of those medications, so looking at their history really well. They should have a good blood pressure, slightly elevated. Burn shock doesn't set in initially, so if you're first on scene and they're hypotensive for any reason, that's not the burn. There's something else going on. Initially, they should be, the adrenaline, they should be a little bit hypertensive, pain and anxiety. So, and IVIO, IOs are great. It's hard to get IVs in burn tissue, so however you get access, that's great. We want you to start these initial fluid rates for any large burn. So if you look at them and say, whoa, that's a big burn, you're getting IV access and starting your fluids at these age-based rates. So children will get 125 mils an hour, adults will get 500, and the kids in the middle, 6 to 13, will get 250. This initial fluid rate is just intended to get them going on something while you're doing all the other things. We found that the time it took to kind of work your way through your assessment, do all the things that are going on in real time, there was kind of a significant lag time before, especially doing the math with the formulas, it might take you a minute. So this way, if we start this right away and then we can keep doing all the things, assess their TVSA, do the math for their fluids, they've got something going so that they're not getting behind. Once you get to your secondary survey and you have the time to do that calculation, then you would switch to their specific calculated rate. And we'll do that math later, so keep drinking that monster there. I was gonna stop and get myself one on the way and didn't have time.
I'm sure there's plenty around here.
Hopefully I still got the mental cognition to get through that later too. No, it's not too bad. We've made it easier. Parkland is the thing that everybody knows, right? We have a consensus formula now, and the math is just slightly easier, so we'll go through all that. Disability, so are they alert, are they oriented? If they're not, why not? It's not your burn. And then exposure, stop the burning process. You know, a lot of people ask about cooling. So the recommendations for cooling a burn are if it's a small burn, so less than 10-15%, you could cool it with cool water, not ice water, for 10 minutes. But anything bigger, so bigger than 15% or certainly bigger than that, we don't want you doing any cooling at all. Stopping the burning process is sufficient in removing the clothing. But if you cool someone who's got a large burn, they're gonna get hypothermic really fast. So we don't want you doing anything like that. The other thing would be chemicals and exposure. If there's any sort of chemical component, then you do wanna make sure that you have thoroughly decontaminated them that may require some water to do. And we would recommend doing that on scene as well. With chemicals, the only factor that we can control to help them not have as severe a burn is the rapid decon. So we do recommend field decon for chemical agents. And any way you can get it done. Diapers on little kids, so those can hold that hot liquid in the diaper. We often see kids who pull hot liquid from a high surface and it pours down them and it pools in their diaper, so not forgetting to get that off of them as well. We did have a little kid come, I can't remember his mechanism, I think it was a scald in the kitchen, and then his mom put him in the shower and called 911. EMS came and got him and brought him to primaries, but during that time, he didn't have any clothes or blankets on him. He was just kind of taken out of the cold shower and then transported. And they were local, it wasn't a long transport time. They got to primaries pretty quick, but his temperature was like 33 when they got him there. He was super, super cold. So always remembering, if you're not like looking at the burn to assess it or trying to find a site for your access, always covering them back up with, I don't know if you guys have like Mylar blankets on your rigs and things, but those are good, they don't expire, so those are helpful. But anything dry and clean, it doesn't have to be sterile, you can just cover them up with blankets or whatever you have at hand. So after you've worked through your primary survey and you've made sure there's no other imminent threat to their life with other traumas or airway issues, you're gonna move into your secondary survey. In your secondary survey, you're gonna reassess ABCs, neuro, do a full head to toe, get your sample history, and then take a look and calculate your actual burn size. This is the rule of nines adjusted for kids. So kids have these giant bobble heads and smaller legs, so we steal a little bit from each leg and give it to the head. And that's also important in the when you're calculating your TDSA for those kids who pulled something hot down on their head. If they burn their whole head, they're already close to a 20% burn. So it makes those type of injuries a lot more severe for them. And then we're going to calculate and start and switch from our initial fluid rates to the burn resuscitation rate. A lot of people ask, like, you know, how long am I going to be with them? If I'm moving them pretty fast, can I just leave them at that initial rate till we get them to the hospital? Our answer is, if you have time to get into your secondary survey, you have time to switch your fluids. So if you're super close and you haven't even gotten to your secondary survey yet, fine, they're on the initial rates. The hospital people can take over from there. But if you have a prolonged transport, some of our teams we teach are like very rural, especially out near Park City and stuff. So they definitely have time to do their secondary assessment and adjust their fluid rate. We'll talk a bit about burn depth. So superficial or first degree, this one's super easy. We've all probably had some experience with it. It's your sunburn type burn. So the skin is red, it may be painful, but the caveat is you do not have any blisters. So once you're starting to get blisters, you're moving into that second degree area. So if the skin is just red, but you don't see any blister formation, you don't need to count that in your TDSA.
So on that, like that guy's shoulder right there, in a day or two is probably going to blister.
Yeah.
So is that still considered?
If it blistered, he has a deeper than first degree. Yeah, he's got
Okay.
superficial partial.
Because usually
So
sunburns
wordy.
don't blister immediately, they usually blister a day or two later, so.
Yeah, and the other tricky thing, especially for first responders, if you're there very fast and it's a scald injury, some scald injuries, if the water or the liquid is hot enough, they'll blister and slough right away. Some of them might take 30 minutes to blister and slough. So if you've got a scald injury that just happened 5-10 minutes ago, it might be that it just hasn't blistered yet. We had one burn consult, they sent us pictures of this kid's scald injury. There were no blisters. So we gave recommendations for like outpatient follow and wound care. And thankfully the provider was busy because he sent pictures back like an hour later and the entire thing had blistered. So that's a completely different picture. Now we're like, okay, now he's actually gotta come here. This isn't a first degree. So in that first window, that can be a little bit tricky too. Superficial partial thickness. So we've burned a little bit deeper into the skin. We're involving like that upper level of the dermis in these burns. These are red, wet, and painful. They may have intact or ruptured blisters, but when they come to us, we're gonna peel all of that blistered skin off in our initial debridement so that we can get a really good look at that wound bed underneath to help us determine how deep it is. Also, if we don't take all that dead skin off, it's just more prone to get infected. Your antimicrobial isn't making contact with your wound because that skin's in the way. So we want it nice and clean it up, and we wash it daily and use Silvadene or bacitracin depending on how deep it is. But we really want to get a look at the wound bed. If it's red, wet, and painful like this, has good cap refill, those are all good signs of a second-degree burn that's going to heal on its own in 10 to 14 days. They're super painful because you've still got all of those live nerves right there, right? As we go deeper, they'll be less painful. That's actually a bad sign. You want them to hurt up front because that tells us we've still got live nerves and we've got a less deep burn. Still in the second degree realm, this deep partial thickness. So we've burned just a little bit further down in that dermis. Some of the skin appendages like hair follicles, sweat glands, sebaceous glands, nerves, some more of those have been damaged. And because of this, the wound bed is going to look more pale and more dry. So you could see in comparison to this first hand that looks really wet and is oozing a lot, these wounds aren't oozing quite as much. It's a bit more dry. These wounds are really a pain in the butt because we don't know if you're gonna need surgery or not. If you have a burn that's this deep over a big area of your body, it's gonna be really hard for your body to heal all of that. So we're gonna need to optimize nutrition, do really good wound care so you don't get an infection to delay wound healing, as well as keeping them warm. So keeping them warm helps that vasodilation, helps the wound heal. They're cold and clamped down, they're not gonna get as good perfusion to their wounds. So a few different factors in our care that we can control in trying to optimize their patient's ability to heal this on their own without skin grafting. But some of these wounds will convert and end up needing surgery. So these are ones we have to have people in the hospital for a while, up to that 10-day period. Usually someday around 7, post-burn day 7, our surgeons have a pretty good idea of what's gonna heal and what's not. And we'll do surgery on the areas that don't look like they're making progress. But yeah, wait and watch, which isn't fun. We kind of just wanna know, do we need surgery? Get it done. But in that realm, it's like, well, maybe, maybe not. And then moving into third degree or full thickness. So these ones are clear right up front. A lot of flame injuries are full thickness and it's clear right up front. The skin is white, dry, waxy, it's leathery and hard. And the patient, this is the guy that comes in and is like, oh, I've always heard burns are so painful, but I must have a really good pain tolerance because it doesn't hurt that bad. You're like, yeah, I wish it did, because it's actually a bad sign that the burn is deeper. In these full thickness injuries, this is also where we're gonna start worrying about compartment syndromes in extremities, and as well as thoracic or abdominal if you've got circumferential torso burns. Another person, if they've got full thickness circumferential torso burns, this is someone you're gonna be intubating right away for sure. And then just watching really closely how much pressure, how much resistance you're having to, give to get that air in, and sometimes requiring like chest escharotomies and things to relieve the pressure in the thoracic cavity so we can ventilate. But on extremities, Again, all this edema that forms that causes the problems with the extremities that have full thickness burns, it develops slowly as we're fluid resuscitating them. So if we're giving them a liter or two an hour to keep their blood pressure up and their fluid resuscitation going, that edema is going to be forming as it goes. So for most patients, most of the time, right up front, you're not going to have an extremity compartment syndrome that you need to address in the field or rapidly. It's usually ongoing in that first 24 hours as they swell that will get those problems. Things you can do up front or in transport that are really helpful are just monitoring, right? Keep checking your pulses, make sure you've got good pulses, and then positioning. So elevating extremities that have circumferential burns, or if it's deep around their face and torso, keeping them sitting up will also help with that fluid formation not settling into tissues from gravity and being dependent. Fourth degree, so this is really common in electrical injuries. So electricity travels along the lower structures, bone, nerves, muscles, tendons, so it tends to burn from the inside out. You might have an entry and exit wound, but along the path between those two wounds, you've got total tissue destruction. So oftentimes these require amputations. We do have plastic surgeons who can do muscle flaps if the wound is right to help save some hands or legs, but a lot of times it just requires amputation. These patients, when we get into the fluid resuscitation stuff, we're going to give them a bit more fluid because we know we have potential for all that dead muscle and how that can really damage their kidneys if they've got that dead muscle, as well as we're only seeing the tip of the iceberg. So if you've only got entry and exit wounds and you do your TBSA, you go, this is a 2% burn, but it's traveled along in their body and you actually have burn you're not seeing. We need to give them a bit more fluid to compensate for that because they're going to have burn injury that we're not seeing on their surface area. Any questions on the different burn depths so far? So the top three: airway, fluids, temperature. Airway and breathing. Inhalation injuries. So we kind of think about these as impacting the body in three different areas. You've got your upper airway, you've got your lower airway, and then you have systemic impacts from carbon monoxide or cyanide poisoning. And we'll talk about each one of these distinctly. So above your vocal cords in your upper airway, sometimes you can have, it's not common to get like a thermal burn to your upper airway. I did see one woman who had a chemical burn, so she went to a barbecue place, I think it was Dickie's or something like that, and ordered a sweet tea, and they had accidentally mixed it with oven cleaner instead of sugar. So she took one sip and had just she was intubated for weeks and had just a horrible burn in her whole upper airway. They had to intubate her unseen because she had rapid edema formation in that area. So you might get some chemical component that could be rapid in this area, but if they have facial burns, large surface burns, then this is going to be more kind of progressive. You could see this kiddo in the ER 1 hour after he pulled a grease fryer, fry daddy, whatever they were making in the kitchen, pulled the cord down on him, and this is 6 hours later. So that edema, definitely by 6 hours, we want to have that tube in or we're not getting it. They're going to have to surgically try to get an airway, which is also not easy to do when they're all swollen because all the landmarks are off. So we want that tube in soon before they end up with this massive edema. Singed nasal hair and smoke. So in inhalation injury, the component that you really have to have a true inhalation injury is a prolonged period of breathing in that hot smoke. So you need kind of a history of an enclosed space fire. So these are your house fires, and these are your car, NVAs, prolonged extractions. Those people have been breathing in that toxic smoke for a period of time, and that's what causes the inhalation injury. We get a lot of consults of patients who are smoking on oxygen, and people think that they may have sustained an inhalation injury from that mechanism, but it does not, because that's a rapid hot flash, but it doesn't have that prolonged breathing of the thick smoke. About the only exception to people sustaining inhalation injury who haven't been in an enclosed space are wildland fighters. So that smoke can be really thick and dense also, and so they can get them even if they're outdoors. And I think in the Maui wildfire that happened a few years ago, or a year ago, I don't know how long, time is weird these days. Most of the fatalities in that mass casualty were from smoke inhalation, and because that can be really dense smoke. But if your patient hasn't been breathing a lot of thick smoke, if it's just the smoking on oxygen, a rapid flash, or another one is barbecue grills, a lot of times people are lighting that and it flashes in their face, that is not enough to give them inhalation injury. So they may have melted plastic in their nose, they will definitely have black soot and all that there. You might have to give them oxygen through a face mask for a while that edema in their nose and we get the junk cleaned out of it, but they're not gonna have that lower lung injury. In airways, so this is just talking about how that edema impacts your airway. You know, your airway is the size of your pinky, and in that little kid or a little kid's, a little bit of swelling causes, you know, a significant difference in their airway diameter. So just keeping that in mind. So things to look for: facial burns, especially if they're deep, if they're labored and breathing rapidly, if they're stridorous, they have a cough, or they're hoarse, or having difficulty swallowing. These are all signs that you're going to need to intubate earlier. This is a bronchoscopy picture of someone with an inhalation injury. Kind of just go in and see how bad the damage is and grade it. This is healthy alveoli, what we want it to look like, and then on the left, your right, is damaged alveoli from a smoke inhalation injury. They'll develop pneumonia, ARDS, they'll be on the vent for a while. It also impacts our fluid resuscitation, so your lungs, if you splay them out, are the size of a tennis court. So that's a large surface area of burn that we're not calculating for in their TVSA. So they have more complicated fluid resuscitations and just a increased chance of morbidity, mortality with combination of thermal and smoke inhalation together. Systemic poisoning, so anybody who has been breathing that smoke, carbon monoxide, this is why we teach any burn patient that you come across 100% oxygen by simple mask. In case there is any carbon monoxide component there, then we're already treating that even before we've evaluated for it. But if the patient's found down, they've had already some sort of cardiac arrest or arrhythmias in the field, these are patients who likely have something like this going on. Do you guys carry cyano kits? Some people do, some people don't. But cyanide poisoning, that's one that's a little bit harder to test for, so really we just do it off of history and clinical presentation. If they've had cardiac events early on, or they're hypotensive, have any arrhythmias, we could give them a cyano kit, and if that's got anything to do with it, may treat. It's just high dose B vitamins, just helps clear the cyanide more quickly from their body. But these are both the byproducts of all the junk in our environments these days as it burns, and then they breathe it in. It has some systemic impacts. So again, what mechanism of injury do we need to have an inhalation injury? Just to recap.
Enclosed thermal.
Great, enclosed, perfect. And then just to recap real quick, all our airway stuff, always give them 100% oxygen right up front. Keep in mind how small your kids' airways are and how much more problematic that's gonna be if they start swelling. If you've got that upper airway edema, definitely intubating early on for those. Securement of the tube, this is another really important one. Let me go back to that kiddo. So you can see how we have his ET tube secured. I don't know if you guys have like the Anchor Fast type devices that they have stickers that kind of stick to the cheek and will hold the tube for you. But that's not gonna work for a burn patient because nothing's gonna stick to their face. And once you get that airway, everybody else's job from that point on is not to lose it. So we use twill tie to tie these around their head, and then we staple it above their ears just to really secure that tube. If you lose the tube on a burn patient who's swollen like that, that's gonna be a real emergency. Fluids, this is where we're gonna get to talk about some math. Everybody ready? Yay. Okay, so LR is preferred, but so many people do not carry LR, right? You guys got NS, that's fine. If we give a patient a couple liters of NS in transport, that's not going to have a big detrimental impact on their electrolytes. You could tolerate a few liters of NS, you're fine. Once you get to a hospital that has LR, they can switch. But for the duration of a burn patient, fluid resuscitation, which is anywhere from 24 hours to 72 hours, if we were giving them NS, we would really screw up their electrolytes and create problems with acidosis and things. So once we get them to the hospital, we're gonna be resuscitating with LR. In your secondary survey, so here's the new consensus formula that we have replaced Parkland with for our center. Parkland said 4 mils, right? Times your TDSA times your weight in kilos. And then they made it really difficult and said, you'll give the first half in the first 8 hours. So you had to divide by 2 and then divide by 8. We just divide by 16 to make our math easier. You get the same number and you don't have to think about all that. So, and we also found that a lot of people were getting too much fluid. We really want the Goldilocks zone with fluid. We don't want too little, we don't want too much, because there's some bad things that can happen if you miss on either direction. So when we found that some people were getting too much fluid, they kind of changed this. So adults are now recommended to get 2 mils, so that's half of what Parkland recommends. 2 mils times TDSA times kilos divided by 16. Kids have less body surface area to their body weight, so they need a little bit more fluid because they'll have more evaporative loss relative to their body. So we give them 3 mils times their TDSA times their kilos divided by 16. And then for deep tissue, so that's that electrical injury that we were talking about, these patients are gonna get 4 mils. We say deep tissue because we're also gonna do 4 mils for those really deep flame injuries, like picturing the campfire kid from your neighbors. If you've got a large burn injury with deep burns everywhere, you're gonna give them 4, because they're gonna have that same kind of tissue breakdown component and myoglobin, things that are really gonna hurt their kidneys. So we wanna give them a lot too.
Sorry, quick question on that. So with the 4 milliliters, is that factoring, because you said with electrical burns, you don't really see underneath what's going on. So even if they're having like a 2% total bottle surface area, is it still factoring in for that, everything that's going on underneath to keep at that 4?
Yeah.
Okay.
So if we took that guy who's only got a 2% surface area, we said he's an adult, let's do 2. And then we just did 2 times his 2% TDSA in his kilos, he'd have a really low fluid resuscitation rate. But he's probably got a lot of dead tissue under there, so we wanna give him a lot. We're gonna do the 4 for him. So that's that. I think on my pediatric slides, it might come up later. But while I'm thinking about it with the kids, the other really important thing to think about is glucose. So pediatrics will burn through their glycogen stores really fast. So we want to give them some dextrose in their fluids. Again, I don't know if you guys carry it or even have that capacity, but just something to have on your mind. Like if this kid hasn't eaten in a while or it's a late presentation, we've had kids who are playing with matches and then they're afraid of getting in trouble, so they hide in their closet for some hours from their parents, right? So if there's a delay, always be thinking about pediatrics and checking the blood sugar, making sure they're okay on that end.
Well, when do you change from your primary to your secondary rates?
So in your primary survey, you say, whoa, this is a big burn, throw an IO in, start the fluids out. If it's a kid, 125. Then you keep doing all of your other work and all your things. Once you get to your secondary survey, where you're doing another head to toe and you're looking at the size of your burn, saying, okay, this is about a 15 or 25% burn, that's when you're gonna do the math and switch the rate. So the time might be variable depending on what's going on, but once you get to that point of your secondary survey and assessing the total burn size, that's when you'll switch.
And then, once you make that switch, if it's 20 minutes into the incident after you started fluids, does that account into your secondaries of how much you've already given, so you may reduce that, or you just
Nope.
keep going?
Nope, just go at the new rate.
Okay.
First responders love boluses. I think all of your other stuff probably just talks. So these are rates. That's a really important point to focus on. These are fluid rates, not boluses. And all of these teaching with EMS type people, when I go, they'll be like, okay, so I'm gonna give them 125 bolus. And I'm like, no. That's a rate, not a bolus. So yeah, we don't do boluses for burns because of the nature of their burn shock. They're progressively losing that fluid, and if we bolus, we've just created, the way that I like to picture it is as if you're holding a funnel and you're pouring into the funnel. And you just want to keep it at that exact tip of your funnel, but not overflow. So if you bolus, you've just given your patient an additional 500 mils of fluid that's going to go into their tissues and into their lungs in the next hour or so. It's not going to do us any good. It's all going to leak out. So we're just trying to match the rate we need that it's leaking, not bolus and then let it dry out and swell up. You know what I mean?
Yeah.
Did you have one too?
I did, I just was gonna ask a question about the TBSA.
Uh-huh.
How bad is EMS at TBSA? Are they, when we do this, are we way over, are we under? And because that really,
All over the place. Some people, we have 3 case studies coming up. So and we have what the EMS calculated them to be and what our attendings calculated them to be. So I do have some examples coming up.
with ways to be better at it?
Yeah, I mean, one way just off the top of my head would just be like a diligent head to toe. We have gotten patients before that they didn't turn the patient and look at their back, and they had like a full back burn as well, so they came way fluid under. So just making sure that you're being thorough in your assessment and rolling them. It's not often something we think about doing, but taking a look at their back, just make sure how much is involved there. And the other one that's tricky is it blistered yet or not? A lot of times if there's some discrepancy, it's because when they come to us, we now have the benefit of time to know, yeah, this area isn't going to blister, it hasn't blistered. Whereas up front, you're pretty soon on and they're scald and it's red, you know, some of those won't blister right away. Some will blister right away and slough immediately if it's hot enough. But counting the first degree, which is hard to tell at first, would be another reason why we have some discrepancy in the field versus once they get to us. Yeah,
What about our obese patients? Does
same.
that change everything or change
No.
anything, add anything? Just
No,
how we-
great question though, but no, I
I'm
mean.
still 18% here.
What do you mean? Is that a fat joke?
What's going on?
That's,
Yeah.
it's
No,
not,
we
it's
still
not a a joke,
the
it's
same-
reality.
The
I've seen
same
a
for
lot
them
of
as
extra
well.
tissue on some.
We do all this math and it gives us this rate that we start at. From that point on, what we're watching is urine output to titrate. So in kids, we want them to make 1 milliliter per kilogram of weight of urine an hour. If they're making too little, we start titrating their fluids up by 10% an hour, maybe 20% if they haven't made any urine. In adults, we want them to have at least 30 mils of urine an hour. So as we're doing their ongoing resuscitation in the hospital, that's what we do. Every hour, how much urine, are we going up or down on our fluids? And if you have some prolonged transport for some reason, or you're with these patients longer in the event of some sort of mass casualty thing, that's sort of where we go from this initial rate is your hourly urine output. So too much fluid. Again, if we're doing boluses instead of rates and we've just given them, a couple liters in transport that's now gonna end up in their lungs, it really does make a difference. You're gonna be more likely to have ARDS. People can get abdominal compartment syndrome, hold a lot of fluid in their belly. Sometimes we've gotten really good at monitoring for that and preventing that and putting in drains early. But we used to open bellies and just find dead bowel in these big burn patients or kids who had gotten a ton of fluid and had developed abdominal compartment syndrome. And then if we give too little, of course, we're gonna get a kidney injury, we can go into kidney failure. There's kind of that organ dysfunction from hypoperfusion. So we really wanna just get it exactly right. So fluid pearls here, just to recap, do not bolus. This is a great reminder for me, unless you have an associated injury, right? We kind of talked up front that if your patient's initially hypotensive, you know that's not from their burn, you should revert to your trauma protocols. Boluses are great in that scenario. So if they're an MVA and they're a big burn and they're hypotensive, you can kind of put your burn fluid resuscitation concerns to the side for a minute. You're gonna be bolusing them just as you would any other non-burn trauma patient. Fluid resuscitation starts from the time of burn. We watch urine output, and muscle memory is a challenge. So I do have up here, if you guys want to come get at the end, these little buddy badges. They're just a good resource to have on hand. They go over fluid rates and burn depth, just a little resource. As well as these posters. I don't know if you guys have any of these hanging in your what do you guys call your firehouse? In your station. That's the word I'm looking for. If you want to take some of these posters to hang up in your station, you're welcome to those too. But yeah, remembering. So we need resources, right? We're not doing this every day. It's going to be hard to remember this 3 months from now if you come across one of these burn patients. So temperature. So this is a really key one for burn patients. That is the vital sign that we kind of don't think about, because ABCs are so important. But for burn patients, right, your skin has lost its ability to thermoregulate. So you're going to take on the ambient temperature of the room that you're in. So burn patients will get cold very fast. If you have blankets, definitely keep them covered up. Mylar blankets are good. Fluid warmers, we tell, are really helpful. But what we're trying to avoid is this triad of death, right? This is kind of borrowed from the trauma world, but burn patients have this same problem. It's kind of that negative feedback loop. You get cold, so you get acidotic, and you get coagulopathic, and this can lead to death. So we're trying to keep them out of this death spiral, and keeping them warm up front is hugely important. Not only to this, but also again for that perfusion that we're talking about. If they're cold, they're gonna clamp down, they're not gonna perfuse those wounds. They could potentially convert and get a little deeper without that perfusion. So just always being mindful of covering them up when you're not needing to look at them or do something, cover them right back up. And yeah, how it impacts the burn wounds here. So there's this theory of these zones of burn wounds where it's white, you can definitely tell that that is a full thickness burn injury. And then as you move away from the burn, you get to burned area that's not quite as deep. If a patient's cold or under resuscitated or over resuscitated, those areas that could potentially heal on their own will convert and need surgery too. So this is just a small picture of those different areas of the burn wound. When it's a larger area, it becomes especially important that we're keeping them warm, we're keeping them perfused, so that we can really optimize the wounds and not have to graft all of them, hopefully. So checking your temperature, warming up the environment you have the patient in, minimizing the time you have them exposed. Fluid warmers are great if you have them, and then plastic is another great material that kind of helps keep the heat in, and warm blankets. We'll just talk a little bit about wound care stuff too. So we don't recommend or need our patients to be debrided or have wounds dressed before they get to us. That's just more time delaying transport to definitive care, as well as then it's just an ointment we've got to wash off to get a good look at the wound. So we just want them covered and dry. If you have dry gauze to throw on them, great, but again, even if it's the blankets, because you're really trying to rapidly transport, that's fine. You don't need to worry about wound care. This is another really important to remember about your burn patients. Burns hurt, right? So being careful with how you're handling them, being careful with where you're choosing to put your blood pressure cuff, different things like that. Just being aware of how you're handling them and remember, just keeping in mind how much pain they are in. Once you cover them with that blanket or whatever sheet, whatever you've got on hand, that helps with pain as well. Because once those nerve endings are kind of covered up even a little bit just with the blankets, that will help reduce pain because those nerve endings aren't exposed to the air, and helps with anxiety too. Kind of cover it up so they're not seeing it. We want, what's that?
I said, because that's why I don't have to see it.
Exactly, yeah, none of us want to see it. I mean, we kind of have to when they get to us, but you guys, hot potato, cover it up and just get them to us. We're gonna be doing IV narcotics, small and frequent doses. We don't want to do anything IM in burn patients because their absorption of that, given all of their burn shock and fluid shifts and things, is going to be unpredictable. So we really want to do things IV, not IM. And then just educating and doing that, diligent calming and presence for your patient and their family members as well is super helpful.
Do you have a narcotic of choice?
We use fentanyl is our primary workhorse, and then Dilaudid as like our second line. So sometimes our patients will hit a point that the fentanyl's just not cutting it anymore. They're needing huge doses, and then we'll switch to Dilaudid.
Just
Are you using fentanyl over something like longer acting?
Morphine is kind of the only other one that's readily available, and there is some data, I can't speak exactly to what it is, but it's like morphine's impacts with histamine, and so in burn patients, just based off some studies that they've done, they don't love morphine because of how it can impact that inflammatory response in large doses like burn patients need. They get a lot of narcotics. Yeah?
What about the use of ketamine for a big burn?
Yeah, we do use ketamine. I don't know about in transport stuff, what your guys' rules and things like that would be on it, but we will often use low dose continuous drips for pain as well. That was you. Yeah, so we do use ketamine too. We also use it for sedation. Was it you? Oh, you're so honest. There. Take one too. We also use it for kids to do procedures, so dressing changes will give them a high dose to knock them out and then be able to do all the main things while they're in La La Land. Okay, so now we'll move into our case studies. So here we go. There was a call placed to 911 stating 2 kids were burned after a spark caught a bowl of gasoline on fire while working on a project in the garage. One child was close to the fire and has a flash burn to the face and burn to their leg. The father was attempting to toss the bowl that was on fire out of the garage, and another child inadvertently ran in front of him and caught on fire. The father grabbed his son to put him out, sustaining a burn injury as well. So, the first thing about this story is mom is gonna be like, what? What were you doing? As a mom, I would read this and I'm like, whoa.
Why is there a bowl of gasoline?
Yeah, the project, right? These dudes, it's the Y chromosome. But anyhow, so here we go. First thing, ensuring student safety, especially with your electrical injury patients, right? PPE, and remembering to follow all of your protocols. Here's some, things to remain prepared. You've got your buddy badges and your posters that I'm gonna leave for you today. So when you get this call, you're gonna be like, oh yeah, where's that badge, where's that poster, right? Your resource. And just being prepared. So our first patient, this is the 10-year-old. We take a look at him and kind of assess TBSA and our primary survey. What are you thinking about this kid? Let's triage these two as we go. So for him, the other way to, besides rule of 9s that I like a little bit better in some burns, is the Palmer method. So the patient's palm is 1% of their body. When you have scattered burns, that could be a much easier way to estimate what the burn size is. Is if you look at, for instance, this arm, you're not gonna look at that and go 9%, because it's not his whole arm. But you could go, okay, his hand's burned, so that's 1%. This part on his wrist here is maybe another 1, maybe another 2 for the back of the elbow, another 1% on his right hand. So you can kind of take notes and add up that way. And then his face. Here's patient 2. This is a 2-year-old. You can kind of see the only real injury we're seeing on him is his calf here. And then we've got Dad. So, right arm, it's another really good way to subtract from 9, right? If you look at his arm and you go, well, it's almost the whole arm except for 1%. I'm gonna give him 8% for that arm. So if we line them up, the first patient, the 10-year-old, initial EMS estimate was 30%. He was alert and oriented, had a patent airway, mild respiratory distress, temperature 36, heart rate 91, 24, 150 over 93, and 98. And he's 28 kilos, previously healthy. Our 2-year-old, initial EMS TBSA estimation was 7%. He was alert and screaming, tachypnic, you can see his vitals there, 13 kilos, also healthy. And then our dad, patient 3, initial TBSA estimate was 17. Alert and oriented, airway good, vitals look good, also previously healthy. With your start and jump start triage systems, right? So that's when they say if there's a big event and you're triaging people, you say, anybody can walk over to me, walk over to me. So you would triage all those people green according to these algorithms. Burn patients will get up and walk over to you, right? So we have a different triage system for burn patients because this is not going to apply. If you use this for those 3 patients, all 3 of them would be green. But we'll actually look at them with their burn in perspective as well and triage them a little bit different. So according to Jumpstart, they're all walking wounded. This is burn patient triage. So green would be less than 10% TBSA and no airway concerns with good vitals. So that little, the 10-year-old that they estimated to be at 30%, he's not in that category anymore. The adult that they gave 17%, he's not in that category anymore. And then 10 to 20% is gonna be your yellow with potential for airway concerns. And your red are gonna be anybody with a bigger than 20%, and any airway issues. So if we apply that triage standard to these guys, your 10-year-old's a red, your 2-year-old is a green, and your dad is yellow. That makes sense? So most important care to be done for each of these guys first, 100% oxygen for patient 1 and patient 3, right? Because they both have some facial burns, they both have large appearing burns, and we're gonna get IV access on them right away and start those initial fluid rates. Our kid is gonna get that initial rate of 250, and dad's gonna get the initial rate of 500. We're gonna keep them both warm and dry and manage their pain. The little one, all he needs is to be comforted, basically. He's not gonna need oxygen, he's not gonna need IV access. His burn was pretty small. So we'll talk about our 10-year-old first. We do our initial assessment, our primary survey, and our secondary survey, and adjust our fluids. So the initial EMS gave him, 30%? And his kilos are, maybe on the next page with a little more info. Find that. Here we go. So this was his fluid resuscitation. He's a kid, so what are we giving him, 2, 3, or 4? 3. So for 22%, when he got to us, he was estimated to be 22. So they guessed 30, we got 22, that's pretty good. That's great. If you're within 10, I think you're doing really good. 3 mils times that 22 times his weight of, looks like 22 kilos, gives us 1,800 mils. We divide that by 16, and we're gonna start his LR at 115. We're also gonna give him maintenance D5 LR because he's a kid and will burn through his glycogen. So we're gonna add some maintenance D5 LR in there. And then start watching his urine output and see how he does.
So it said total fluids running concurrently, so when you add the D5, that's additional fluid?
Yep,
Okay.
yep. And we leave that running at their maintenance. When we change every hour, we just adjust the LR, but we leave the D5 LR. This is our ABA referral criteria, but basically we want you guys calling us for any and all burns. It doesn't necessarily mean they need to be transferred. We have a really great outpatient clinic. We can assist, in guiding wound care for community hospitals, things like that. But really, thermal burns, any burns greater than 10%, definitely inhalation injuries, all kids, chemical injuries, electrical injuries should definitely be referral criteria. This is our pediatric trauma networks triage workflow for where a pediatric patient goes. There's been a lot of confusion in this arena with kids, whether they go to primaries or come to us. So you can see, basically, if you've got a kid with a greater than 10% burn involving hands or special areas or airway concerns, yes, then we come over here. All scene flights need to go to primaries first. If there's any associated trauma, those need to go to primaries first. So essentially what happened is our ED, at the U, we're the only unit that takes kids. So our emergency department isn't very, comfortable, well-versed with kids. We had a kid come to the ED and they were like, suddenly, I don't know, maybe they've turned all their staff over, but they were like, what do we do with the kid? We don't want these kids coming here. So now we send them to primaries. Primaries does their initial trauma workup, make sure there's no other concerns. And then we're connected by a bridge, so we just walk them over to the burn unit after they've had their trauma workup, or any immediate airway needs met over in primary's ER, and then they'll come to us. So if it's not a scene flight or concern for trauma, those types of PEDS patients can be direct admits to the burn unit. But really it's kind of case by case. The transfer centers and our attendings will work it out. There may be some kids in that second category that our attendings are like, I'd like them to go to primaries first for whatever reason, but definitely if it's a scene or there's trauma or airway, primaries first. So patient 1 was transferred to primaries, and then we brought him over to us. Our next little one, actually this is dad, our yellow one. So his estimate, 17% TVSA. He was getting that 500 mils an hour. Secondary survey. See what the burn team got him at, 9.5%. So that one is a little bit more off, but still not terrible. Our docs love to do that with the 0.5%. It's like half of a palmar surface. I'm like, yeah, you're that accurate. They'll even do 0.25. Like, we round up or down. But yeah, they think they're that accurate. So he had just, again, so he's less than 10%. He doesn't even meet criteria for an official burn fluid resuscitation need. So he was just put on some maintenance fluids. And came to us. And then the little one, which is the small leg burn, estimated to be 7%. His leg, if you remember, he ended up having a 4%, so pretty good, pretty darn close. And really no needs for fluid resuscitation, give him a bottle or whatever for comfort. And he's one of these in the green area of here, less than 10%. We can, sometimes if we need to admit these patients for whatever reason, pain control, maybe the rest of their family's on the burn unit, so we're gonna bring them in too, or whatever reason, or if they've got a home to go to and people to care for them, we'll just do outpatient care. This is just a list of some supplies that can be good to have on hand in the event of needing to care for burn patients. So those fluids we talked about, Mylar blankets, the securement methods for your endotracheal tubes, dressing supplies. Again, that would be if you're gonna be wearing some sort of mass casualty thing, we're gonna be holding on to them for a while. Or if we're just recommending outpatient care. But if they're transferring to us, you're not gonna be doing any of that wound care stuff. This is our MedPick app, which is awesome. We've just implemented in, I don't know, maybe the last 10 years or so. Before technology and we could send pictures, we would get calls for burn referrals from Mon Canada. All this patient's got a 40% burn, we fly them all the way down. They get to us and it was like a 5% burn, and now we've got to get them back to Canada. Of course, a lot of people don't have resources and they've got now a giant bill. So this has helped us a lot in appropriately triaging patients whether or not they need to come to us. So we use this frequently to really help us figure out what patients need. So this kid was managed on outpatient side. This leg, that's kind of the one I was telling you about, how you won't see blisters. When you take some dry gauze and push on that skin, you can see how the whole thing kind of opened up. So it's not just that you guys don't do it all the time. Burns are masqueraders. They can be really hard to tell up front. Is that actually burned or is that just soot? And really just taking that dry gauze and pushing on it and seeing if the skin sloughs will help figure out. But pain management is good in that phase of things because that hurts when we start doing that. these are just some resources.
The leg on the left was the same leg as the
Yeah.
right? Oh, wow.
Well, the one we saw earlier, so I can flip back real quick so you can see. It'll be easier if I come here. Oh, no. Just go. Where is it? Here it is. See that left leg? All this skin here.
Oh,
Here. It looks like there's one ruptured blister there. Maybe another little one forming there. What looks just maybe like some tiny little blisters. But really, that whole thing was burned. And all sloughed off when we debrided it. This here is just some resources that we have for outpatient care. There's videos and things for doing wound care, blister removal, resources for patients and doctors around the valley on different components you need to be considering for burns, infection, diet, etc. This here is a really good one for you guys. If you want additional education, we have this website that has recorded educational sessions and topics on all things burn, all things frostbite, lots of different kinds of topics in there. They're about an hour long each, and they cover for CMEs or CEs if you guys need those. So you can just log on, watch a video, and then we send you a CME certificate. There's a lot of good stuff on this. I'll move so we can get, you're good. It does have a lot of patient protected information and stuff in some of the sessions. So we do have to keep it under lock and key. You'll have to request access when you go to that site, but that'll just send me an email and I'll just go in and approve it so then you can have access.
When you guys are having like innovative patients, you're saying that like, you know, what we have isn't really sticking to them, it's not really helping that much. Is there like a better method we could use? We don't have like the same tape that you do. Obviously, we're not gonna staple it to them. Is there a better method that we can use out here before we get to you than the two tapers?
The twill tie is, I think, pretty great. It's not gonna be too expensive. It's not gonna expire, so that might be something worth investing in getting. And then just, you don't have to staple it, but as long as you tie it, put it above their ears. We staple it above their ears once they get to us, just because the tie will break down the top of their ears over time. So you kind of run it behind their head, the ball, the back of their head, and then over their ears. But if you don't have a staple.
I mean, ours like Velcro, they go around the back of their head, so if those don't work as well as what you've seen.
That one might be okay. What I would say is use your judgment, because I have seen some people come in with those ones on, that's more Velcro and around. You guys have got them kind of packed in there and
The
sitting
Thomas
as
ones
well.
work good, they work good. for
Yeah,
burn.
so that might work well. But the ones that are supposed to stick to a face, those are the ones that don't. But that's, now that you mention it, I do recall seeing someone come in with more of a Velcro one. So just, and then using that and just keeping it on your list of things to keep an eye on. And another reason to keep your patient just well sedated during that. Everybody get a picture of this that wanted? So just to kind of button up, don't let the burn distract you. Stay focused on all the stuff you already know and are well trained to do. Follow your ATLS principles. Secure the airway. Adhere to your fluid protocols, especially if it's someone who's hypotensive initially and should not be from their burn. Keeping them warm. Keeping their pain and anxiety under control. Sunblock. Level up from the pen, right? You got a pen already, you get the next best prize. And then do what you do every day. A little plug for our burn camp programs. This is a really special area where we have tons of engagement with our fire community. We love it. The fire, I don't know if you guys have gotten involved or want to, but you can definitely reach out to our burn camp director. There, I think it's too late to do now, but you guys could come. Have you guys heard of the chili cook-off? Oh, it's awesome. It's gonna be October third weekend in October. It's down at the Real Stadium. It's grown so much. We used to just do it in the parking lot of Valley Fair Mall. And now, last year we did it at the stadium. They only gave us like a part of the stadium. And it was so packed that this year the whole stadium is our event. And they even moved a concert to accommodate it. So there's over 30 booths of fire, burn, just different people from the community, making their chili and a competition. There's some really good chili. So one of our old burn patients is a chef. He has like a show on the Magnolia Network. He's from Montana. He's like the coolest dude, and he's a professional chef. He comes down and helps our burn nurses with their booth. So last year he smoked all these, like, I don't even know, but there's some amazing chili, beer, whatever. It's a big party. It's fun. So come check it out. And then next year, sign up to do a booth for your station. It's way fun. And all the proceeds go to burn camp. So we have a preschool camp. It's just a day camp. There's a sleepover camp for our school-age kids where they go to a camp in Tooele and spend the whole week overnight in cabins and stuff. Different firehouses come up and cook the meals, volunteer each day, so breakfast, lunch, and dinner. Different fire crews are doing that, so it's another really great place to get involved, but it's just super, super fun. There's a river trip that they do as well for the adolescents, and then one for the adults. There's more programs that they're starting in the winter months, so they're doing for our kids growing into adolescents or teen or young adults. They're doing with like job skills, training. There's a rock climbing clinic that they do. It's just a really awesome place for our survivors to be with their peers, and really, really rewarding work. So definitely come to the chili cook-off and get involved in this area. You guys will love it. The last one of the resources. The other thing I'll say, if you ever do have a burn patient that you transfer to us, we do loop closure for our first responders and medics, or fire, whoever. So if you want to know how that patient did, you can reach out to us, just email. I'm not our usual coordinator, Courtney Lawrence is. She had a baby, so she's on maternity leave. But that's her email right there. If you reach out and say, hey, how's this patient doing? We'll do a chart review on them, tell you exactly what we found from transport records, what you did well, what maybe you missed, what their TBSA ended up being, and kind of how they're doing, just because that piece is so important for you guys to have, right? You see these people. The one guy who is kind of our lead fire in the camp world, I think he works with, what's the main one in Salt Lake that has ones all over? Unified. He works with Unified, and one of the kids that he responded to on a call when the kid was like 3 is now graduating high school, and he's been able to see him at camp all these years. So just really awesome opportunities with camp. And yeah, reach out to us if you ever do want some of that information on someone you care for. Any other questions?
I love your guys' feedback. It comes out so organized in a paper and it gives a thorough review of your patient. It's
Yeah.
really nice.
Cool, so you've actually gotten some from us before.
Yeah, I like it.
Good. Yeah, I mean, that is so important.
I like your feedback too.
You do?
Maybe you don't need it.
Actually, he does a good burn upper lip right now. It senses
Yeah. What kind of burn nurse would I be if I didn't, help you with your upper lip burn
Thank you.
care?
I appreciate that.
Okay, well, thank you again
Thank
for
you.
having me out, and yeah, it's great.
Great class, thank you.
Thank you.
Thank you.